within the Health Systems Collaborative, I have been working on the POETIC study. And POETIC stands for the Provision of Essential Treatment in Critical Illness or COVID-19. And during our time as part of the POETIC study, we've been looking at various angles to see how we can improve critical illness care. Now, this presentation won't be focused solely on presenting POETIC's findings, but I'll use our experience as a POETIC study to discuss a multi-method approach with a bit more of a focus on understanding health facility assessments. So I've split this presentation into two parts. The first will focus on providing an introduction to health facility assessments, just getting everyone on the same page with what they are and what you can do with them. And then the second part will then dive a bit more into our experience as a POETIC study and using a multi-method approach for us to get our results. When I first started looking into HFAs and took a deep dive, and I'll refer to health facility assessments as HFAs throughout the entirety of this presentation, I found two descriptions that I think represent the evolution of health facility assessments. The first, taken from a document that was created in preparation for a World Bank workshop on health facility assessments, is quite vague. And that's because at the time, health facility assessments were coming into a global focus. Previously, assessments done at health facilities of the services provided were mainly done for specific fields such as maternal, child, or HIV care. And that was within the remit of the programs. It was not something that was owned by the academics. And so each particular program developed their own process of evaluating the services provided for the fields that they were interested in. And it was during this time when there was a greater understanding or greater need for everyone to understand what's happening at a larger facility level, that those individual programs then also went on to develop quite large, much larger health facility assessments. And so at the time, there was a plethora of different types of assessments and not one singular process or singular understanding of what a health facility assessment should be. And moving forward, the second description, I think, more accurately describes what a health facility assessment actually is and what it does. And that's because at the time, the Measure Evaluation Project was created, and this was created because there was a much larger, a rather global understanding, global need for both information to be created and used to understand what wasn't working at the facility level within health systems, but also what was working and needed to be scaled up. And so the Measure Evaluation Program came about to help governments and health institutions develop ways of creating this data in order for them to use it to create more targeted programs as well as improve specific aspects of the health system. And that's why this description, I think, is a bit more tightly packed. Now, one of the reasons that health facility assessments came about was because many people working both at the program level but also within governments realized that the type of health services offered, as well as the state of those services, influences who is going to use those services, and in the long run, that influences the health outcomes of the populations that are being served. And so many governments, as well as health institutions, understood that it was very important to not only wait for the health outcomes data could be produced during the usual surveys, but to have these periodic surveys that will give them an insight into the state of services, because that would then give an indication of what sort of health outcomes they might expect for a particular area. But it's important to highlight that health facility assessments were not designed to replace routine data collection. Instead, they were designed as an external validation for those routine data. So then the districts as well as national governments could understand whether their data is really representative of what they thought was happening at the health facility level. Now, as I mentioned, many different programs spearheaded the creation of different types of health facility assessments. And so there's a plethora of health facility assessments that exist. And in this table, I've sort of signposted a couple of health facility assessments that focus on looking at the whole system, because they are health facility assessments that focus on looking at specific diseases, particularly HIV, or looking at particular fields like maternal health. Now, these health facility assessments are quite variable. Some of them, like the service provision assessment, focused on providing a national level of information and therefore would be more costly, take much longer to do, and require specific training for it to be achieved. And therefore, this type of assessment was only recommended to be done every 3 to 5 years. On the other hand, you had the Facility Audit of Service Quality, FASQ, and the WHO Service Availability Mapping, SAM, which were designed to be done at a district level. And this meant that they were done on a smaller scale, were low cost, and didn't require very specific training or particularly trained individuals to carry them out, and could be done on a more frequent basis. Apart from varying in scale and size and the time required to do them, the health facility assessments also varied with the type of data that they were able to provide. Some were much more comprehensive and looked at readiness, availability, as well as the quality of services, while others only looked at functionality because it was the preferred type of data that this particular program or initiative were looking to harvest. Now, the positive side of this for many countries was that they could then pick a health facility assessment that suited the budget that they had. But the problem with this was that different types of health facility assessments were taking place within the same country, depending on the partnership that a government or health institution had and the type of funding they had available. Now, one problem that this created is that you had these different types of data generated by the health facility assessments, which weren't so easy to merge together, particularly for national governments who are trying to plan and trying to utilize their health budgets in a more targeted way. And so because of the confusion that the different types of health facility assessments were creating and the lack of a standard for which health facility assessments should meet, the WHO, in collaboration with academics, health institutions, as well as other interested parties, created the Harmonized Health Facility Assessment, and I've highlighted that in green. And the Harmonized Health Facility Assessment was designed to act as a precursor to an accreditation process. So it would provide a singular standard for which different health facilities should be aiming and allow each country to then categorize the health facilities accordingly and see what each facility should be aiming for. But one thing it took into account, because it was influenced by the different pre-existing health facilities, was that each country might not want to do the same level of health facility assessment, again, depending on the budget and the time that they had available. So it's created a sort of a modular approach where you can pick the module that you think is suitable for your country at the time, and then focus on that and then build on to then add additional models if you want a more comprehensive assessment. And this process of creating, oops, let me just go back. This process of creating the Harmonized Health Facility Assessment really started in about 2016, and the first documents as well as the website going live happened in 2018. But because this has been such a long process, and as you can see from this document, which was only released December of 2021, it's not yet come into wide use, although it has been noted Kenya was the first country to conduct a harmonized health facility assessment in roughly about 2018, 2019. But within this document, you have all the suggested questions as well as an area for modification. So different countries can modify the questions to best suit their context, but there's also standard core questions that are recommended for use. Now, within this harmonized health facility assessment, I mentioned that there are different modules, and I think I've decided to focus more on the health harmonized health facility assessment, because this is the standard which the WHO wants every country to move. And I don't want anyone to be tempted by the other existing health facility assessments. I won't give any further details on those. But if anyone is interested in finding out a bit more about that, I can send out a document, guidance document produced by Measure that goes into detail on the different other health facility assessments. So within this modular approach in the harmonized health facility assessment, you have service availability that can be assessed, where you look at whether certain number of staff are present, as well as certain specialties of certain categories of staff, as well as the number of beds. And this focuses more on saying, yes, this is there, and no, this isn't there. And the second module, readiness, focuses a bit more on functionality. So this will look at whether something is there, as well as whether it's in use, whether you've got particular guidelines that staff are trained on, as well as the various levels of qualification that staff have at a particular level. Again, the focus is to try and help countries develop certain levels within the health facilities within their countries, as well as standards to which each particular level should meet. In the quality of care module, this one, it takes a bit more of a qualitative approach and then can look into the standard of different types of services that are provided. And then it was also recognized that it's important to include a management and finance module, because the cost of different things such as medication also limit or increase the access that populations might have to services at a particular health facility. Now, countries can either opt for a particular module, and there's a guide where you can just have one particular module, or there's a combined questionnaire that has all the sections involved. And there is particular guidance on how the harmonized health facility assessment should be conducted. Because previously, with the other different types of health facility assessments, such as the FASQ, some of them would recommend that any kind of health worker working at a facility could conduct them, while others required enumerators trained by the census department to conduct them. But for this harmonized health facility assessment, it goes into detail with who the data collector should be, but more specifically, who the data collector should target to find out information. Because I know for anyone who's been involved with this type of assessment and speaking to health workers at working at facilities, not everyone has access to the same level of information. And so a junior nurse is not going to have access to the same level of information as a nurse that's working in an administrative role. And so this harmonized health facility assessment recommends the use of the most knowledgeable person available on the day of the survey. But they've decided not to be too prescriptive about the title, because that will vary from country to country. And then one other thing that's important to note about the harmonized health facility assessment is that it recommends a specific platform on which the data should be collected. So the CS Pro application is one that's available to download on the WHO website, as well as training provided for people to become comfortable and familiar with its use. And within the CS Pro program that WHO have partnered to create, there's also means for analyzing the data. Because again, another problem that was encountered previously was that you would then have these different types of data analyzed in different ways from the various types of health facility assessments. But with this approach, you have a singular way that you could analyze the data, but also various options within that where you could then create some data visualization. Now, this is an example. I know it's quite difficult to read because of the small text, but this is an example of the type of questions that you have within the harmonized health facility assessment. So the one with the purple border represents the module 1, so that's the service availability type of questions. And you can see there's an option if something is lacking or someone doesn't have, or a certain facility doesn't have particular services, you can then move on, or recommend it to move on to another section. And then the pink border represents the service readiness type of questions. And you can see those are a bit more extensive, and rather than yes, no questions like the service availability. And the orange border represents the quality of care, and the red border represents the management and finance section. And I decided to put up print screens because you actually can't access the CS Pro questions without particular application and having a specific password that allows you to access certain aspects of it. So I think they're trying to make sure that not just everyone is using it at different times. And the website for the Harmonized Health Facility Assessment went live in 2018, and you can access the different modules as well as the introduction to the Harmonized Health Facility Assessment. However, it should be noted that some of the modules haven't gone live just yet, and it's noted on the website that they will go live in roughly 2022. Now, I haven't gone into depth in the type of analysis that takes place within the Harmonized Health Facility Assessment, because that's actually a specific module that's listed on their website, but you need specific accreditation to access the module that's on the analysis. But I know you can do a range of analyses using R and various statistics within it, as well as data visualization. But there's also some more categorical data that are generated by the Harmonized Health Facility Assessment. Now, that's been a whistle-stop tour on health facility assessments, getting everyone up to speed with what the standard is that the WHO is recommending, but also where we've come in terms of development of health facility assessments. I'm now going to switch focus to the POETIC study, give everyone a bit of an introduction to the POETIC study, but use our experience to also critique health facility assessments and our experience of them. So POETIC study was started in mid-2020 after the start of the COVID-19 pandemic. But long before then, Dr. Tim Baker and Dr. Otto Schell, who are principal investigators for this study, had recognized that there was a lack of standard but also quality care provided to patients who were critically ill within hospital settings. And when they recognized that there was a lack of a standard as well as the low quality of services provided to those who are critically ill, not only in low and middle income countries, but also in high income countries as well, they developed the Central Emergency and Critical Care Package. And this is a package that consists of 40 processes and 67 hospital resources that they recommend as the standard in order for hospitals to deliver the optimum care to critically ill patients. And this is something that can be delivered in all wards, in all types of hospitals across the world. And I highly recommend that you check out our first paper from the POETIC study, which I've pasted here. And yes, this is a shameless plug for everyone to read our paper that goes into detail about the development of the essential emergency and critical care, which came about from a global consensus of different experts. And as part of the POETIC study, we had 4 work packages which focused on 4 aims. And for this presentation, I'm going to hone in more on work package 3, which is the one that I've been working on. And work package 3 is the one that looked into readiness and allowed us to then use the health facility assessment. So within work package 3, we had 3 objectives, and objective 2 and the associated research question, how ready are hospitals to provide care for critically ill patients, is the one that I'm going to focus on and use that to discuss our experience. Now, we conducted POETIC in Kenya and Tanzania and used the same methods in both countries, but our approach for Kenya was slightly different, and that's because of the political climate in Kenya that differed at the time of COVID from Tanzania, as well as the access that we had within the 2 countries. So for POETIC, in order for us to understand and explore how ready facilities were for an ECC standard of critical illness care, we used 3 methods: the health facility assessment, in-depth interviews, and patient journeys. And we did those at 5 facilities in both Kenya and Tanzania. And we selected these facilities based on their inclusion in the clinical information network, and I'll come into a bit more detail about why we did that. And we also selected these facilities based on other criteria, which we're going to lay out within our paper, which will be submitted for publication soon. Now, one of the reasons why we opted for a multi-method approach was pragmatism. So the COVID-19 pandemic meant that it would be unethical to do or to carry out each of these methods to the standard that they're normally carried out. For our health facility assessment, rather than using the standard that I've talked about, the harmonized health facility assessment and a modular approach, we decided to use a pre-existing tool that was created for the Kenya COVID health facility assessment study. One of the reasons for that was for ethical approval. We knew that it would take a very long time in order to gain ethical approval for our own health facility assessment study and tool. And during a time when you've got a fast changing disease like COVID-19 that everyone was very uncertain about in 2020, we thought it wouldn't be ethical for us to extend it, knowing that the results of POETIC were then going to help influence and improve the care provided to many of the critically ill patients presenting with COVID-19. Now, the Kenya COVID Health Facility Assessment actually used 3 WHO COVID-19 specific modules that were created for different countries to assess how ready they were to provide care for critically ill patients during the time of COVID-19. Now, this differed slightly from the modules that are recommended by the Harmonized Health Facility Assessment, and they have also published their paper on with findings from this Harmonized Health Facility Assessment that lists out the specific modules that the WHO created. Because even though we've got these standards that we've talked about for the Harmonized Health Facility Assessment, we have to look at what is pragmatic during the time that we're operating and the type of problem we're trying to tackle. And unfortunately, while the Harmonized Health Facility Assessment provides a very good standardized way of approaching assessing services at health facilities, it would have been more time consuming for us to try and get to that standard and provide the training necessary to meet that standard. And for the Kenya COVID HFA study, they used the REDCap tool to collect their data rather than CS Pro, because there was a greater familiarity, particularly at the facilities where we were collecting our data, because the REDCap tool is one that is used within the hospitals that are part of the Clinical Information Network, CIN, within Kenya. And so it made more sense to use a platform that more people are familiar with, and that wouldn't require a longer period of training. So the Kenya COVID-19 study used that as a platform to collect their data. And while we used bits of REDCap as well, some of the elements, some of the 67 hospital resources are not ones that were included within that. So we had to make some adjustments for us to collect data that was relevant to the POETIC study. And we then exported our data to Excel, because again, that was the more pragmatic option for us based on the study team that we had and the time that we had available for training. But one thing that we did do was triangulate our HFA findings with in-depth interviews and patient journeys, because we understood that as we're not going to get to the set standard for each of the different methods, it's important to have a variety of ways of checking our results and making sure it's true to what was actually happening on the ground. But one thing that we did notice quite quickly with our health facility assessment was that the data presented a very positive view of what was happening. I know it's very difficult to read the text that is displayed here, but I think what I want you to pay more attention to is the colors that you're seeing. And we know that green universally means everything's good, very few problems, and you can see that for most facilities, there's only one particular item or one particular area where they have reds and therefore didn't have them. Now, this information was striking because as a team, with some of our team members actually working at the facilities included, we knew that this wasn't really telling the full story of what was happening. And this is one of the disadvantages of health facility assessment, because depending on the type of information you're collecting, you can then generate a slightly more misleading picture of what was going on. Now, we know I mentioned earlier on, the health facility assessments were required for, or were created for periodic use. This would be handy when comparing it with what was happening previously, a year or two before the COVID-19 pandemic had started, where perhaps some of these categories may have been very red. But in terms of utilizing this to understand whether hospitals are ready to provide critical illness care at an ECC standard, this wasn't particularly helpful. And I mentioned that one of the disadvantages of health facility assessments is that a lack of in-depth questioning into potential problems can give you slightly misleading results. If we only had our health facility assessment data, we might have felt that actually further work to improve services are not required in Kenya. Each facility is ready to deliver the standard of critical illness care, and therefore the additional benefits of an ECC standard of critical illness care would generate negligible results. And it's important to understand that one of the reasons why HFAs might not be useful for answering all the questions is that they don't answer some of the why questions. For example, why, if all these items are available, why the standards of care are not being met, or why people are not using services within this particular region. And this is something that would require a more qualitative approach, because qualitative methods allow us to dig deeper into the problem and generate a context-specific understanding of what is actually happening. And these are some of the results that we've got. So in our HFA, the oxygen section was largely red, where each facility noted that they had oxygen present in order for them to care for critically ill patients. However, when we look at the responses that we got from the in-depth interviews, you can see here that while oxygen was available, it wasn't actually sufficient, which meant that patients were not always getting the benefit of the presence of oxygen at this facility. Additionally, with other types of equipment, such as suction machine, those again were noted to be present on the health facility assessment. But here we can see that for the staff who are dealing with the patients on a day-to-day basis, they find it challenging to only have one suction machine, because it means that when you've got more than one patient requiring it, the other one is more likely to deteriorate. And that's one thing that our health facility assessment couldn't account for. It looked into availability. Yes, an item is present. No, it's not present. But it didn't look into functionality or sufficiency. So we just noted that something was present, but weren't able to look into whether it was working, whether it was within the areas that needed it, and whether there was enough of that particular piece of equipment or medication for the patient cohort that needed it. Another method that we used were patient journeys, and this is a method that not everyone might be familiar with. And patient journeys really developed within the NHS and have been used across different specialties, but now across different countries. And they provide a patient-focused understanding of what is happening within either a particular department or at a particular facility. And it looks at the sequence of care, the different stages that a patient is going through, and whether it's meeting the standard of what we think should be happening at that particular stage. And it's increasingly used within the field of patient safety to reveal the perspective of patients, their encounters with staff, as well as to analyze the care system. And one of the great benefits is that it allows us to have a more human-centered design. So at the end of the day, we want the health service to be one that serves the patients rather than servicing itself and being present for the sake of being present. But one thing to note about patient journeys is that they are subjective. We cannot generalize the experience or the data generated from one patient journey to every other department, every other facility, and every other district that we're investigating. But it does give us pause for thought about whether the aspects of the system that we think are working are really working to the standard that is expected. And this is an example of patient journeys, because in the beginning, patient journeys really started as patient journey mapping, where you'd map out where a patient had been, how much time they'd spent, and what had happened. But you can also have a more narrative approach to patient journeys. And that's what we did within POETIC. We used a more narrative approach to patient journeys.